My question's for you, Dr. Yu. The husband-wife team that you showed, where the wife had the negative IGeneX test for Lyme,
Yes.
did you check for mold? Because you talked about root canals, which is great, but did you check for mold?
Not for that particular case, but it's a good idea. But that particular patient, when you tell them to remove the 6 root canals, you know what happened? They don't come back. But I see that pattern mimicking just like a Lyme with the root canals.
And was there like a long-term follow-up? Did you see her?
She's from another state,
Okay.
and people don't want to do it. They don't want to face the idea of losing their tooth.
Okay.
Thank you. My question's for Dr. Boyd. First of all, your talk was awesome. Thank you so much. I found it fascinating and learned a lot. So I know, well, I'm not an anthropologist, but from learning from you, I know you do a lot of observation of what's happened in the past. I'm curious, kind of two-part question, how much you are able to see what's happening in real time to make projections of what might happen in the future. And more specifically, I'm curious if you have an opinion on things like surrogacy and IVF and how that might affect natural selection and evolution as far as optimal genetics being passed on.
Well, the first part, you're saying like predicting the future from what I see now relative to an individual or a species?
Just kind of the big trends that you've been able to observe over the massive amounts of time periods that you've studied. And as we're having new things introduced or new disease processes, kind of what you predict as far as if this isn't corrected, we'll see the morphology of the face change further in this way, or is it entirely retrospective?
Yeah, the changes that we're seeing in, again, don't use the word craniofacial anymore because you're ignoring what it's just like nursing. You can't talk about nursing unless you also talk about weaning. They're paired phenomena. And when we're talking about what's happening to the face and the respiratory system, it is totally ill-adapted. It's a mismatch. We have an ancient genome. Everything, all these survival mechanisms that we have, and most of them are above the clavicles, right, for speech and breathing and smelling and talking, hearing, is that it's been adapted over really millions of years, even pre-human, but since anatomically modern humans 300,000 years ago, everybody who survived childhood had to have had all those things functioning well, or they wouldn't have survived childhood and lived to become an ancestor. And so we know that. So we are all genomically capable of really having 32 teeth, but so what? I mean, who's going to start treating 2-year-olds? I'm really an odd person because I'm comfortable doing that and I want to do that. But maybe there's things we can do while kids are still in utero to help the mother sleep and eat better, sleep better, breathe better, that the kids aren't born with these deficiencies and that they don't need as much pressure expansion and that's the way it's always been. So I guess what I'm saying is there's nothing that's been happening to our genome. Our genome is intact. We're fine. 99.9% of people land on the planet with an intact genome. And that means the potential to have an optimal for nose breathing craniofacial respiratory apparatus. They just do. So the way I see it going is until orthodontists and pediatric dentists and GDPs who see kids, until we start getting active while a kid's still in utero and certainly during the first 3 years of life, it's going to continue to go south. And there's going to be a lot of problems. So I don't know if that answers your question. And what was the second part?
The second part is, as an anthropologist, things like surrogacy and IVF. So
in vitro fertilization?
Yes.
Oh, and what about that?
Kind of how that, as far as your understanding of evolution and natural selection that you mentioned in your lecture, how that might be artificially changed based on how we're able to procreate in a way that we've never have before in the past.
Yeah, if you have what is it? A 1N gamete meets a 1N gamete and forms a 2N zygote, which turns into an embryo, which turns into a fetus. I mean, I don't really think it matters if they're made in a test tube or inside a uterus. It's just, but how it's nurtured once it implants, and how the placenta actually, you know, gets fed from the environment, from the maternal environment. You know, that's just, did you see that story today? Some Caucasian couple that had in vitro fertilization and the kid's Asian, and did anyone see that in the news? Like, and the company that supposedly, you know, did the test tube fertilization said, oh no, there must have been an Asian milkman or something, you know, that it wasn't their fault. So that's just a little side note. You'll see it on CNN tonight. So I tell you the truth, I've never really thought about it. I just.
First of all, I wanted to thank all of the speakers today. You're great, and thanks for sharing all the information, first of all. But I had two questions for Dr. Levy. One is that you had mentioned the magnesium levels, and in the past we've always looked at intracellular red blood cell magnesium levels. What would you advise would be an optimal range for humans?
Well, I don't have the numbers at the top of my head. I would only say that, well, in looking at the available tests for magnesium, there's gradations of relevancy. The blood test is only good to confirm that you're deficient. If it's normal, it means nothing. The red blood cells have a little extra value, but they don't have the cytoplasm and the mitochondria like the other cells do, which are the main storage sites of magnesium in the body. So the red blood cell and the platelets, what they sometimes measure, which are like just flecks of cytoplasm from other cells, or from the thrombocytes, I believe. So it's an improvement on a blood level, but it's still, if it's even in the top range of whatever the normal range is for that, still falls short. They do have some experimental tests where you can look specifically at the cytoplasm of cells. That's even better still, but you can have a normal cytoplasmic level still being fed by a depleted mitochondrial store. So it's really only ultimately when you do a tissue biopsy, a muscle biopsy, for example, that you get a true reflection of mitochondrial content. And the test I was talking about, which is taking cells underneath the tongue and the frenulum area, they've worked with this for a couple decades, so it's not a brand new methodology. They've correlated it as being quite consistent with the levels that you see in a muscle biopsy or in a left atrial appendage biopsy that they've gotten, you know, in some cases of cardiac surgery. So right now it would appear that that's the best test. Especially important, you might say, well, how important it is. Well, I just mentioned earlier with different supplementation, you might be getting to the point with IV or the liposome or something else, you're taking it and, oh, you're a little out of it. And, well, you kind of need to know if you're a little out of it because you're maxing out on your magnesium and you need to take it less frequently or not. Then at that point in time, I would suggest getting that test.
And that actually kind of led perfectly into my question number 2 for you. When you said there was a supplement that could help you produce vitamin C, and then you mentioned the bottle of scotch a day, I don't think that was the same supplement, right?
Well, I talked about this briefly, I think, at the Vermont conference, and I have a lot more experience with it then. But it's a nutrient polyphenol derived from olive leaf extract waste debris, and for some magical reason, it allows you to skip over what appears to be an abnormally placed stop codon, epigenetic, not genetic, of the transcription of the RNA that the ribosome takes place. Without the product, it's like gum on a zipper. You're cruising along and you hit this hunk of gum and you can't go any further. Incomplete protein, no physiological effect. But all the literature I've looked at on read-through, which is what this phenomenon is called, it's just gobbledygook. Nobody knows if the codon is dissolved, bound, or it's very unclear as to what it does, except for the fact that you do end up having an intact protein where you didn't before. And there's some other genetic diseases, thalassemia, for example, where things like resveratrol, a good quality resveratrol, can bring greater than 50% of thalassemia patients to the point where they no longer need blood transfusions, which again means you've overcome that genetic defect that allows them to start making normal amounts of their own blood.
Thanks.
Sure.
Thank you.
Thank you, everyone. Thank you.
I don't want to be commercial. You can ask me afterwards. Okay.
And thank everybody for making such a great conference. Dr. Levy, I was curious to know your thoughts on what we do in dentistry called periodontal probing. We use an archaic tool to go down into the sulcus around the tooth. Many of them are infected with caustic biofilms, and we're moving that biofilm from one area of each tooth to another. And in the light of these newer studies showing evidence that oral pathogens are in these arterial plaques, they've probably been there all along, but I wonder how much dental hygienists are contributing to periodontal disease.
Ooh, you're speaking to the choir here. I wasn't anticipating that, but it's an interesting question, and I have a very strong opinion about that. Number one is, I know I'm speaking largely to a group of dentists here, I don't believe overall flossing is good for you, okay, unless it's done perfectly. Number one, it traumatizes the gums every time. And furthermore, if you just get a water pick, even after you do your dental floss, you're still going to bring stuff out with a water pick. So the thing to do, and I don't see the point, and I think you're making this, of measuring these pockets, okay? Yeah, it's a nice way to see if the pockets are getting resolution, but I've had a limited experience, but it's been very positive, that this one patient had advanced periodontal disease. I mean, it's like they didn't even have any gum growing in between. It's just like little squares down, no gum. And I got her on the water pick with a few tablespoons of 3% hydrogen peroxide and warm water. And in 2 weeks, she was growing gum up between her teeth. I mean, I'm not going to try to oversimplify the periodontal profession, but there's a lot of good things that are not being done on a regular basis, and I'm not sure. I'm optimistic they could cause a great impact if they were done on a regular basis, but water picking with a little bit of hydrogen peroxide and warm water, and you'll do fantastic, in my opinion, as long as you stop the smoking. I want to add this. We always, as a cardiologist, we always talk about, well, smoking causes heart disease. Well, now that's a correlation. Smoking causes advanced periodontal disease, which causes the heart attack. You're the dentist. Tell me how many heavy smokers you've ever seen that have normal gums. None.
This is for Dr. Lechner, and it's so good to hear you again and the progress of your work, and it's very important research. And we've heard different points of view as far as scanning the jawbone and seeing the cavitation, seeing the problems. Years have gone by since the cavitat has been used a great deal in the United States. I don't know about Europe. I suspect it really is not used very much. And the cone beam has become more and more commonplace. So how do you see this new device, the CaviTau, that you described, as competing with the cone beam, or is perhaps superior in some respects from the cone beam or other methods for discovering the jawbone disease, the cavitation problem? So just give us some perspective on that, if you would.
Yeah, thank you. First, thank you for your compliments. I don't see any competing situation between CBCT and the ultrasound, because of course we use CBCT, including the Hounsfield units, to validate our ultrasound machine. So first we need it. But many patients are aware of these radiation things, although we had other opinions today. And for us, the process is basically you need OPG, phantomogram, then you do the ultrasound, and if you find in certain areas a positive ultrasound scan, then you might add your CBCT to be sure to give the patient the good information. But for the patient to see the red color on the ultrasound scan, it's a wonderful thing to give him the idea of what's going on inside the bone. For lay people, the CBCT is a bit complicated for interpretation. And basically, we want to lower the radiation. We want to lower environmental stress, which is also oxidative. I hope I answered your question. Yeah.
This question's for Dr. Levy. So you mentioned iodine. You didn't mention what type of iodine. Nacean iodine, Lugol solution, potassium iodine?
The iodoral. Lugol solution
Lugol.
is fine. It's basically liquid form of iodoral.
Right.
But
Okay.
I see no reason to subject yourself to that foul taste when you could just pop the iodoral. But that's a la Dr. Brownstein. It's his recommendations I completely endorse and support.
Secondly, where's one going to get insulin?
It's over the counter.
Oh.
You go to any pharmacy. That's been, I think, in place for 20 years or so now. They didn't want to make it difficult for diabetics, so you could just get it over the counter. You should.
Any particular
anything's
form?
possible. You might find one pharmacy where the pharmacist is hard-headed. I don't know, but the rule of law is you get it over the counter.
Okay, in what form?
Just Humulin U100, Humulin 100.
Okay.
And you can buy syringes from them too without a prescription, or very easy, you go online and order syringes. But you don't need a whole bunch of syringes. You could keep using one over and over again. It's not like it has to be super sterile because you're just putting a tiny amount in solution.
Okay, thank you. This is to Dr. Boyd. No one mentioned Francis Pottinger's work. Are you familiar with Dr. Pottinger?
Yes, he worked with Weston Price, and
No, he didn't actually work with Weston Price. He worked with his father, who was a physician also, and they did work on cats. So what they did with the cats is they gave them the perfect diet, and then they gave them deficiencies.
His son Brent, his great-nephew, Brent Pottinger, is now a physician, but about 10 years ago, he helped form the Ancestral Health Society and gave me all the original manuscripts from his work. And he actually was a colleague. I don't know if they worked in the same lab, but they were aligned. The Price Pottinger Foundation is...
Yes, PPNF, yes.
Yeah.
Okay.
So, and he worked with cats, and it was somewhat supportive of what we have learned mainly from Lieberman at Harvard about the importance of diet and chewing stress and building the palatal facial sutural complex. So yeah, I'm familiar with it as much as I can be. I've read everything that's been written about him and by him, but you know, there isn't all that much. But it's powerful, and he does have film. There's actual footage of these cats that, yeah, interesting stuff. That's great. That's impressive. You know about them.
To Dr. Haley, when do you think your product will be available to the public?
I can tell you the FDA has given us 3 lines of research that we have to complete, and they'll be completed early this spring. I mean, February, March, and we plan to put in an NDA, a new drug application, in March. That's our plan right now. But after you turn it over to the FDA, you know how that goes. Yeah.
Thank you.
Quick comment. I first came 7 years ago, and it was the beginning of my journey to recover my health and discover this incredible world of both integrative medicine and biological dentistry. And I think what's exciting is that there are more, sort of clinical partnerships being developed, both at the big research level, but also in local communities. And I think that's important. And I also think it's really important to reach out more into the public that still has very little awareness of this. And patients sort of start on one side and get into the other. So I did want to just put in a quick plug. I think everybody's waiting room should have these 2 books, The Hidden Epidemic by Dr. Levy, and Accidental Blow Up in Medicine by Dr. Yu. I have to disclose I'm editor of it, so I apologize for that. And he has a few they both have copies available. But I guess just brief remarks. What do you think is most important to really breaking through so that people don't have to be sick for 20 years like I were before they begin to discover this, and that it makes it easier for you to practice and refer across the disciplines needed to help your patients?
The question from me? The question was from me?
All of you.
Oh, all. Okay.
From my point of view as an internist, whatever we do, we just overlook the dental aspects of it, go beyond the x-rays. That's what I'm focusing on. And the infection outside of besides the dental infection, there's what the parasite, fungal, protozoal infection. If you can handle that, it's like some people can smoking until they're 95 years old to fine, with you don't have to be on an extreme diet, and you'll do fine as long as you have a good handle on those infection and environmental toxin. Any comment?
Well, for me, the body is, it's very important for it's living from signaling pathways. It signals. Okay, we are concentrating on bacteria, we are concentrating on toxins. That's all right, but at the end, it's a system that's reacting on signals. And one of these signals are these biochemical fixed, now we have about 28 cytokines. Or otherwise, it's also psychoemotional signals we are submitted to. Yeah. So signals is the, regarding the signals and derailed signals is possibly a future of holistic medicine.
The only comment I would say, if you listen to my lecture, we talked about the body's tight control of free iron. And I took that with regard to the fact that it prevents oxidative stress, the production of hydroxy-free radicals. There's another function that takes place in the body that requires free iron, and that's bacterial replication. You have to have free iron to reduce the ATP to deoxy ATP to make DNA so bacteria can replicate. When you keep your free iron levels very, very low, which the body tries to do, you don't have infections taking off rampantly. And that's one of the advantages of keeping a low iron level in the body. And that's one of the things that the compound we've made, one of the side advantages it'll decrease the infections you have. I would tell you, and a lot of you know me, and I do a lot of duck hunting. I'm outside in the wintertime. I haven't had the flu since I started taking OSR in 2006, or any bad infection, cold or anything. And I think it's because I keep my iron levels, the free iron levels, very low.
You know what they say.
Anybody else?
I have a few questions. For Dr. Yu, when you give those patients all the antiparasitic and antiviruses, do they get a lot of side effects? When you give the patients the antiparasitic medicines and antiviral medicine and the antifungals, do you give them all together and do they get sick? Are they all antibiotics or do you use herbal medicine, binders?
Yeah, I initially used the natural herbal medications until 2001. There's a quantum difference between natural remedies and using prescribed medication. And I've been experimenting with a parasite medication dose and different combination based on the meridian testing. And some of them are counterintuitive, but if you give high dose of a parasite medication, you have a less side effects than giving low dose parasite medication. So people ask the question, how can you possibly get away giving massive amounts of ivermectin, parental palmoate, praziquantel, tinidazole, etc.? And I say, so what kind of dose did you use? They use like a much low dose based on the PDR. So when you give a low dose, it may not be killing the actual parasite, and they'll make them to move around. It create even bigger side effects than the giving actually killing dose. This is from try and errors. I wrote about the whole phenomenon. It is in my book, using about certain dose you have to use. Standard dose for ivermectin is at 3 milligram. Typically, I use 36 to 48, 50 milligrams of ivermectin and never use it alone in combination because there's resistance. You have to use 2 or 3 different combinations to kill the darn parasite. And you have actually less side effects. And then you use in combination. So when you go through the parasite cleansing, you realize you have to think of the fungal problem, and then you have to do the protozoal. You have to go through the cycle. It takes 6 months or a year. I don't have a 100% success either. Maybe there are other factors involved in it, but it's a try and error, so it's purely a clinical observation. And I'm sharing this information because I think it's really too important. One of the important aspects about the run test, I have Dr. Leishner's lecture in London in June, so I look it up, and then they talk about Th2 respond to run test, and they produce the effects on the eosinophil. The eosinophil is going after the parasite. So they're all interconnected. And anyway, that's the dose I wrote in my book talking about that.
Okay, thank you. And Dr. Lechner, how do you get a test for Rantis? Is that a blood test? To test for Rantis? How do you test for Rantis? R-A-N-T-E-S?
What she's asking,
is that a blood test?
A blood test or the actual sample, the fatty tissue from the sample?
Yeah. How we get how we analyze the fatty samples for Rantis contents. This is your question?
Yeah, and
this is multiplex.
Oh, so you send the tissues?
Beard-based multiplex analysis.
Okay.
This is very common in big machines. Yeah.
Okay.
And you can do this with 28 cytokines, which are known up to now. Okay. And this cytokine network, what I showed you, is basically much, much more complicated. It's not to say Rantis is creating breast cancer, please, yeah? But it just contributes to a possible circle inside a real complicated network.
Thank you. And Dr. Levy, for a type 1 diabetic that is already having to have injections of insulin or maybe it's on a pump, how will be the best way to figure out the right dose for vitamin C and magnesium?
How to figure out the levels?
The best dose for a type 1 diabetic, because we're all insufficient of magnesium and most likely vitamin C. So what would be the best way to figure it out for a patient that is a type 1 diabetic and is on an insulin pump?
I mean, how to figure out how much to give? Well, vitamin C, you give as much as you need until you get the response that you want. And magnesium is the same way, except there is a saturation point with the magnesium, which is why I said you can take it for a while, but if you start to develop any sleepiness or weakness or this sort of something, you need to check on your blood pressure to make sure that, which is your ultimate barometer of whether you're going too far. But for 95% plus of diabetics, you're not going to come close to giving them too much insulin or too much vitamin C or too much magnesium. So you just, and as I mentioned during the presentation, many diabetics are especially low in magnesium and don't really start to come around with regard to responsiveness to insulin until you significantly increase the magnesium intake. One of the things insulin does is help get magnesium in the cell. That doesn't mean that's the only way to get magnesium into the cell. So you supplement generously, you'll get magnesium into the cell. It's just that if you're looking at other applications like wound care, this, that, or the other, putting some insulin with the magnesium or with the vitamin C will get that inside the cells and rapidly promote healing. But the point I wanted to make about that is a lot of diabetics who are insulin resistant never really respond well until you first get the magnesium up.
I have a question both for Dr. Lechner and Dr. Yu. In one of your cases, Dr. Yu presented a patient that had radiolucency on the radiograph, but only after doing the AMA, you determined only 2 of those infections were active and the other 2 were inactive. By using the tools that we have, Dr. Lechner, the cone beam and the CaviTau, would the results be the same or kind of different in terms of things you would pick up?
Well, that's a good question. We now have about 200 ultrasound scans with our machine, and they nearly 100% correlate with the Hounsfield units in the CBCT. The problem of CBCT is when you try to validate the bone precisely adjacent to the implant. Yeah? You get these shadows from the X-rays, and it's the same in our experience underneath the root tip of a root filling. Yeah? It's really complicated here to get a precise Hounsfield unit interpretation. But the ultrasound shows you immediately the red spot, shows you immediately the diminished mineralization of the bone.
So I guess the follow-up question, Dr. Yu, if we did an ultrasound of those areas that you determined would...
So I think what I'm picking up is a functional disturbance. So there is a toxic effects disturbing the meridian system before there's a bone damage. So what I'm picking up on your case, I think we are sharing is that before there's actually bone damage, it may take 5%, 10% bone damage before pick up on the CBCT, the cone beam. I'm picking up before that toxic effects. Now, I don't tell my patient to pull the tooth. If it's general aches and pain, maybe they can do ozone. But when I'm dealing with a cancer patient or ARS, MS patient, I don't have time. So I'm racing against them. I'll tell them to go after them, pull the tooth, but make sure do DNA tests to find out what kind of microbes are in there. And many of those cases have entamoeba. This is why I'm so fascinated with the rentis controlling. Maybe it has something with the eosinophil, with the Th2, maybe going after the parasite, and the rentis going up, or rentis going get the signal going to the eosinophil, going after the parasite. That's my thinking.
Cut me off. So.
Okay. My question is about bruxism. It's for Dr. Boyd and Dr. Yu. Can you talk very quickly about bruxism and airway in pediatric patient? And I need a referral that's close to Penn. I'm 45 minutes from Penn. And Dr. Yu, can you talk about bruxism to parasites in pediatric patient?
Yeah, I learned actually from my Mexican patient. Mexican patient tell me, in Mexico, when children have a grinding teeth with a bruxism, they give parasite medication, the problem goes away. From my meridian point of view, it's on lymphatic system, and I check for the bite. When it only takes a few seconds to check, and then when I use the right kind of a parasite medication, it also balances around. So I know we're dealing with a bruxism. And then you treat with the parasite medication, often this bruxism goes away.
In children?
Yeah, I see all the time.
In what medication?
Whichever the response, which medication based on meridian testing.
Yeah, I'd like to know more about that. Well, first of all, what is the, why? Why are they doing that? And in my pediatric dentistry training, and I trained at a very good residency at Iowa back in the 80s, and the consensus was that, what do you tell a parent who comes in and says, my child grinds his teeth? And Dr. Full was my clinical instructor, and he said, you congratulate them that they're not living with an alien because all earthlings do it. And it's ubiquitous was all he was saying, but there was no solution. Is it stress? Like, is that 4-year-old worried about who he's going to be playing with at preschool? And since I've come into the realm of sleep medicine, there are actually good studies published on this, that it's really not stress. It's want for an airway, is that when they reposition the mandible and there's teeth and they're clenching, you'll hear it, because it's like in CPR, you come up and you do it, or if you do anesthesia and intubate, the first thing you do is do a jaw thrust and bring it forward. Well, it's an autonomic compensation that the child is perceiving a hypoxic event, and it actually shows up on polysomnograms where you can actually see the rhythmic activity. They're also arousing themselves out of delta slow wave sleep. That's when you oxygenate the least, and that's that's how it's best explained now, that there is want for an airway, and the kid is solving their own problem. They also will sleep on their belly with their butt up in the air, and they'll curve their neck, and they'll move around a lot, and they'll sweat, and there's head banging. There's all sorts of things that are related to muscular activity, and it almost always coincides with frequent arousals out of deep sleep. So that's kind of a long explanation that it's not stress, that they want to breathe.
Yeah, so I'm looking at the parasite as a stress, and not only that, these children are grinding their teeth, they usually have a nightmare, night terror, bedwetting, all those associated with, and then when they grind them so hard, they become affecting their airway. So this is the kind of pattern I learned from my patients. They say in Mexico, when children grind their teeth, give them parasite medication, problem goes away. Just a comment.
Well, talking about bruxism from the view of Rantis, Rantis is blocking the opioid receptors in the brain. And with blocked opioid receptors, you have lower level of positive neurotransmitters. And this lack of neurotransmitters is producing your nightmares. Mm-hmm. Possibly, possibly.
All right, that's all we have time for. Gentlemen, thank you so much for coming and spending a little extra time for the forum.